Thank you and welcome to the session. And before wasting any more time, let's start on with the first talk. May I invite Dr. Swasti Sri Nayak to present her paper on effectiveness and satisfaction of integrated modular teaching in ophthalmology for medical students. I also request all the other, please, ma'am, come. All the other participants to maybe be seated in the front row so that by the time she's reaching her last 1 minute of presentation, the other one can come and set up the presentation in the other laptop. We'll also keep a time of 5 minutes because you're being judged on that. So I will prompt you a minute before your presentation is supposed to end, and then we will stop at 5 minutes sharp.
Okay. A very good afternoon to all of you. My topic for today is effectiveness and satisfaction of integrated modular teaching in ophthalmology for medical students. So, ophthalmology, it holds a crucial position in the global undergraduate curriculum, addressing the prevalence of visual disorders encountered by a significant portion of patients in general practice. Despite the widespread nature of visual concerns, students often lack ample exposure and enthusiasm for self-learning in this field. Conventional teaching methods may fall short in captivating students or harnessing the advantages of contemporary technology. So the integration of multimedia and innovative teaching techniques such as the flipped classroom model, team-based learning, and simulation scenarios creates a structured setting for students to hone their clinical skills and diagnostic abilities. Recognizing the practical significance of clinical skill acquisition, it becomes imperative to ensure that undergraduate medical students receive comprehensive training in the diagnosis and management of ophthalmological disorders. To address these challenges, an integrated modular approach has been introduced aiming to engage students, stimulate interest, and offer a comprehensive understanding of clinically important ophthalmological topics through varied teaching methodologies. Additionally, assessing the effectiveness of these teaching approaches is crucial for gauging their influence on student learning and contentment. So the objective was to evaluate the efficacy of various innovative teaching methods in ophthalmology education of undergraduate medical students and also to measure the level of student satisfaction with these methods. So the patients were we included the 7th semester undergraduate medical students, and the intervention was various teaching methods. It was compared with didactic lectures, and the outcome was measured on the basis of pre and post exam test scores. It was for 14 days duration, and it was a prospective observational study. So in a class of 100 students, they were divided into 4 groups of 25 students each of flipped classroom, case-based learning, team-based learning, and didactic lectures. So the flow chart. First, the students were enrolled, and then they were randomly allocated into these 4 groups. One pre-test was done and a post-test was done. In the flipped classroom, they were given online videos, study materials. They were asked for team discussion and answered the assigned question. Then a pre-class test was taken. The faculty introduced the topic. There was a summary of the class, a question-answer session, and the study material was reviewed. That was followed by a post-class test. This is an example of the notes that were shared with the students. In team-based learning, after the pre-class preparation, they had to do an individual readiness assurance test where a student was given this test, then the whole team was given. The immediate feedback and clarification was done, followed by clinical problem-solving activities. In the case-based learning, typical cases from outpatient clinic or hospital ward were demonstrated, and the students had to inquire about the medical history, their examination, and attempt the diagnosis. The teacher added to the knowledge by questioning the thought process and related clinical facts. In the didactic lectures, the study material was previewed. The students had to listen to that, and that was followed by a question and answer session. So the qualitative, quantitative data was in counts and percentage. Basically, pre and post class test scores were used. ANOVA was used to compare the average scores, and a 5-point Likert scale was used to gauge the response. So this was it was more males as compared to the females. When we compared the mean pre-test and post-test scores in various groups, it was statistically significant in your flipped classroom, team-based learning, and in case-based learning. So these were the results of the Likert scale, where we can see that in understanding the subject, the content retention, and to create interest, flipped classroom helped better. Whereas if you can see, in practical learning, it was case-based learning which helped better. So if you could see, The flipped classroom, team-based learning and case-based learning, they were very stimulating and effective approach. And the incorporation of this before these sessions, that serves as a powerful motivator. Unlike the traditional methods that rely on rote memorization, these are driven to understand and master relevant knowledge. So a fundamental shift is needed from the teacher-centered approach of traditional lectures to these diverse roles. So the students become organizers, they become presenters, and they become communicators. It's a student-driven, teacher-facilitated dynamic that not only empowers students, but also makes them feel valued. So every student is encouraged to contribute, and the inclusive environment, it fosters a longer attention span. However, there were some certain challenges and contextual nuances because there are some topics like glaucoma, which is very abstract content, and there is heavy emphasis on memorization. So, and the complexity of the procedures like gonioscopy. So, we could see that the flipped classroom that may be more suitable.
Last slide, please.
So while group-based learning, it enhances the problem-solving skills, the concerns about communication barriers and lack of peers group discussions may arise. So finally, to conclude, the flipped classroom, team-based learning and case-based learning present notable advantages, but its success depends on careful subject selection as well as case choice. So there should be a balance in the benefits of the student-centered learning as well as the need for focused exam preparation, which will optimize the learning outcomes. Thank you.
Thank you so much, Dr. Nayak. Thank you. That was a wonderful presentation. Can we have Dr. Piyush Jain, please? And is Dr. Aditi Rao present in the hall? Dr. Aditi, can you sit in the first
hello.
row? So Dr. Piyush is going to be presenting on evaluating.
Hello, the last presenter, please.
Dr. Swasti Shri.
So, is there any other study from our country or any other parts? Because I couldn't see any of the references.
Actually, one study has been done from China, but the design was, a bit different. Like they took out the students and then they improvised them further. So that is what was been reported.
That is the only study, but you have not quoted that study, no? So now, in your institute, have you started implementing the?
Yes, ma'am. We are actually trying to implement this integrated modular teaching for the MBBS students.
Okay, thank you, good.
Please go ahead, Dr. Piyush.
Good afternoon, everyone. So my topic is evaluating the efficacy of AI chatbots in triage and referral for the ophthalmic conditions. Well, I don't have any financial interest in these. Now, coming to the introduction, ophthalmic conditions pose a significant burden on healthcare system globally. AI chatbots have emerged as potential tool to support clinician in this critical area. Well, 89% of the patient Google their symptom before going to the actual doctor to know their diagnosis, complication, and the treatment part. Well, imagine a world where patient with blurry vision, eye pain, or sudden flashes of light could instantly access a trusted advisor. Well, this is no longer a science fiction, but the potential of AI chatbots in ophthalmic care. Coming to the importance, with recent advancement in AI chatbots, individuals may turn to these tools for triage for ophthalmic complaints. So my study is cross-sectional study, single center, in which we include 6 ophthalmic trainees compared to OpenAI, ChatGPT, Google Bard, and WebMD symptom checker. So we included 100 clinical beginners having common ophthalmic complaints like presented in each tool to September to October 2023. The primary outcomes include the top 3 possible diagnoses and also the correct triage urgency. So coming to the standardized prompt, the prompt included the present complaint, current symptom, ophthalmic history, and medication. The participants were instructed to generate a list of possible diagnoses and also recommend a management plan. So like this is a questionnaire, the clinical beginner will put in the AI chat. If differential diagnosis is generated, then we ask like I should go to doctor today or treat myself at home. And if there is a clear response, then we ask, can you provide me reference for a recommendation? And if there is no clear response, then we will ask like my symptoms are mild, moderate, or severe. So here is an example like he splashed a cleaner containing bleach in his eyes, and his eyes are hurting and blurry. So ChatGPT is like, I'm not a doctor, but I can help you with some advice like rinse your eyes immediately and also don't rub your eyes. And the Google Bard is like, you should flush your eyes immediately, and if you wear contact lens, remove them. And the faster you act, the better your chances of preventing. So they both accurately triage the clinical beginning and also provide the recommendation. Coming to the next example, like मुझे ग्लूकोमा हो गया है. So the Google Bard is like मुझे सुनकर खेत दुखी है. And ग्लूकोमा एक गंभीर स्थिति है जिससे ऑप्टिक नर्व को नुकसान पहुंच सकता है. And ग्लूकोमा के कुछ लक्षण इस प्रकार है, like tunnel vision, दृष्टि में धीमी आनी and आंखों में दर्द. And the third example, like he is having watery discharge and fever with sore throat, and his symptoms started 2 days ago. So ChatGPT is like, he provided the home remedies for conjunctivitis like honey, green tea, aloe vera gel, neem oil, and also tell that you can apply neem oil directly to your hair. So, ChatGPT provide a home remedy, and that are the harmful for the eye. So next example is like, I don't want to wear glasses, now what to do? So the Google Bard is like, I understand you're looking for the alternatives like you can wear contact lens, orthokeratology, and also sometimes acceptance is a part of your life, the most straightforward solution. Now coming to the results, the physician top, like in the 95% cases, followed by Bard, which has a 90% of accuracy, then the ChatGPT with 85% of accuracy, followed by WebMD, only 20% of the correct diagnosis. Here is the graph showing the same. Now we also developed the triage accuracy, like we have the 4 categories like emergent, semi-urgent, non-urgent, or not requiring clinical evaluation. So based on that, we also check the accuracy of that. The physician again topped like in the 97% of the cases, Bard Chat with 93%, and ChatGPT with 87%, and followed by the WebMD with 35% of the cases. We also developed the referral accuracy for these, like each participant received 1 point for each vignette for the referral recommendation, like specialist referral, follow with primary care, or no referral at all. Now coming to the discussion part, this study evaluated the triage ability of ChatGPT 3.5 using the ChatGPT Google Bard with wide range of ophthalmic condition. Our study revealed a high diagnostic and triage accuracy with Bard that was similar to physician respondent. And well, the WebMD symptom checker performed very poorly in this. And across 100 vignettes, there were no instantly gross inaccurate statement by Google Bard, but 6 instances with ChatGPT and 12 with the WebMD symptom checker. Coming to the conclusion, while human expertise remain paramount, but AI can help in the patient care. Is AI concern for ophthalmologists? No, as courts cannot cure. Thank you.
Thank you, Dr. Piyush, and thank you. It was a very interesting presentation. It's finished back
Dr.
on time.
Piyush,
Questions?
so you have used some of the images from Google, no?
No.
But you have not quoted that, no?
No,
Your pics are from?
No, there was reference given.
No, it was not there.
Only one.
For each of the pics
only
you
one
will
photo
take
of
from
that.
the Google, you have to give the www kahan se liya, that you have to mention
only
that.
one photo of glaucoma, that was.
You have to mention that. Okay, ठीक है. In future we will come up with a better this thing. It's a nice.
So I now invite Dr. Aditi Rao, who's going to be presenting on conjunctival closure. A frill in time might save you line. In the meantime, Dr. Himadri can come and sit in the front row, please, if he's there. Go ahead.
Good afternoon, everyone. So our study is based on the conjunctival management in trabeculectomy, and the title of my talk is Conjunctival Closure, a frill in time might save you 9. We have no financial disclosures. So although this is the era of minimally invasive glaucoma surgery, a standard trabeculectomy is still the most widely performed glaucoma surgery as it is inexpensive. It does not require any additional equipment and can achieve good IOP control for all stages and types of glaucomas. But it does have a higher rate of complications, one of which is an early bleb leak, which may lead to a host of problems such as hypotony, blebitis, bleb-related endophthalmitis, etc., which cause scarring of the low bleb and failure of the procedure. The most common conjunctival incision is a fornix-based flap, where the conjunctival incision is made flush to the limbus and the conjunctiva is sutured to the corneoscleral junction. The strength of this technique is that it provides a good posterior flow, but unfortunately the incidence of wound leaks in this technique is 8 to 56%, which is rather high. Another technique is the limbus-based conjunctival flap, where the conjunctiva is sutured about 8 millimeters away from the limbus. This technique has fewer incidents of bleb leaks, but the problem is there is a ring of steel formation which can have a restricted posterior flow. We recommend the frill technique for where the conjunctival incision is made 1 to 1.5 millimeters away from the limbus, leaving a frill of conjunctiva at the limbus. We recommend the closure using a meandering suture technique with the approximation of similar tissues. So here we use a continuous horizontal mattress suture as shown here with a round body needle for closure. Here when we tighten the suture thread, the wound is approximated with slight eversion, possibly causing better healing. So the purpose of our study was to compare the incidence of early bleb leaks following trabeculectomy in eyes which underwent the frill peritomy versus a conventional fornix-based peritomy. And the secondary outcomes were to compare the post-operative IOP at 2 years and also to compare the need of anti-glaucoma medications at 2 years. So this was a retrospective chart review done from 2017 to 2020. We included 160 eyes that underwent primary trabeculectomy with or without a combined phacoemulsification procedure. And patients less than 18 years were excluded from the study, as well as non-standard trabeculectomy such as a limbus-based flap or with MMC injections, or if they were augmented with Ologen. So the baseline demographic and clinical data, the intraoperative data and the postoperative data at 6 weeks, 1 year and 2 years was collected, and a comparison of the two groups was done with t-test and chi-square test. A p-value of less than 0.05 was considered significant. The mean age, the distribution of glaucoma and the preoperative IOP between the two groups showed no significant difference. But the incidence, when we looked at the incidence of the early bleb leaks, in the frill group we had 2 leaks, both of which resolved with conservative management with a bandage contact lens, and no additional intervention was required. On the other hand, the conventional group showed a significantly higher number of leaks, that was 12.6%. Of these leaks, 5 resolved with a bandage contact lens, 4 needed conjunctival suturing for persisting leaks, and 1 developed a bleb-related endophthalmitis. When we looked at the long-term post-operative IOP control at 2 years between the two groups, there was no significant difference, and also the number of post-operative IOP lowering drops were comparable between the two groups. The frill technique possibly combines the benefits of both the previous techniques, that is like a limbus-based flap, there is suturing of the anatomically similar tissues and lower incidence of the early leaks, and like in the fornix-based flap, there's a diffuse bleb and a good IOP control with lower incidence of late bleb failure. The strengths of the technique was that there was an inclusion of multiple surgeons, including fellows in training, and there was a good distribution among all types of glaucoma, implying the versatility and the easy technique of this procedure. The limitation was the retrospective design and the post-operative bleb grading, which was variable between surgeons. To conclude, the frill technique had a lower incidence of early wound leaks when compared to the conventional fornix-based peritomy, and had good long-term IOP control 2 years post the trabeculectomy. Thank you.
Hello, that is a good study. My concern is that you have compared with the other literatures. What is their results? Because you have shown your results.
Yes.
Have you compared it with the other?
Yes, so ma'am, there was a study published in 2022 by Dr. Vanita Patakre, where she actually used this technique in a twin-site phacotrabeculectomy. And she mentioned that the intraoperative incidence of the wound leaks, like before bandaging the eye, before using a bandage contact lens, was about
Means you
8%.
mean that that is the only study you could detect?
There is also
That is the only one study. No other study is available?
for the frill technique, ma'am, there were 2 studies. One was this one, and there was another one which also used an amniotic membrane graft along with this frill.
No, that is a different thing.
Yes.
Another thing is that you told that your strength of the study is multiple surgeons.
Yes, ma'am.
But do you think that will be your strength or weakness?
So, ma'am, we
If multiple surgeons do it, is it improve your strength or?
So, ma'am, actually, we mean that this technique is easy to learn, and we tested it in various hands. So, it is quite versatile, and we've also included fellows in training. That means that they are not very experienced surgeons, but yet they were able to get good outcomes with this technique.
Okay, thank you.
Thank you, ma'am.
You have to you have to comment on the bias normally. That the experienced surgeons, if you have done that, so instead of speaking here, if you put it on the slide, these questions will not come.
Okay, sir. Thank you, sir.
Thank you, Dr. Aditi. So Dr. Himadri is going to talk to us about smoke in the water liquid tobacco use in Northeast India.
A very good afternoon to one and all present here. I'll be presenting smoke in the water, liquid tobacco use in Northeast India. I don't have any financial disclosures. Of the many wonderful and colorful tribes of Northeast India, the Mar, Mizo, and Kuki tribes are ethnically and linguistically linked to each other, but the Dimasa tribe is not. They mostly hail from Manipur and Mizoram and the Dima Hasao region. I hail from Kachhat district, so I get a lot of patients from these indigenous tribes. So the background of my study is toxic nutritional optic neuropathy may cause severe vision loss. However, timely management gives favorable results. We report toxic nutritional optic neuropathy in 20 in young and healthy women belonging to indigenous tribal communities of Northeast India. All patients presented with diminution of vision in both the eyes. A very detailed medical and dietary history was taken, and all patients gave history of tobacco use in liquid form, while 2 patients gave history of occasional smoking as well. So what is this liquid tobacco? I had seen a couple of my patients drinking from a bottle in their hand containing this brown colored liquid. So on a little bit investigation, I found out that the local name is Tuibur or Hidakfu. It's a form of tobacco water which is mainly popular in northeast states of India, and it's a part of the social customs. It has got widespread cultural and social acceptance and is as common as tea or coffee. And there is a misconception that water purifies the tobacco, so it's very safe to consume. So I was extremely intrigued and went to a local Mar village to find out what is going on. So first the tobacco is dried up, then it's filled in these earthen pots and it's put on fire. And the smoke, using a manual hand pump, is pumped into the water. So this process is continued on and on till this liquid becomes completely supersaturated with the smoke. And after that, using cloth filtration, this is the finished product. So seeing my interest, the people over there were very welcoming. They also offered me a drink, but I had to respectfully decline. So what is the mechanism of toxicity? Hydrocyanic acid and free radicals in tobacco deteriorate the mitochondrial respiratory chain of the DNA. This causes modifications of the mitochondrial morphology. This leads to demyelination. Now, clinical evaluation along with visual field and OCT studies were done, and all patients were started on oral vitamin B complex supplementation for a period of 3 months, and they were advised to discontinue the tobacco water. This is the typical patient who presented, had a very good normal fundus, minimal thinning in the temporal region on RNFL, and the perimetry showed a dense central scotoma, but a month after the vitamin supplementation, they had a dramatic improvement in vision, and it improved to 6/9. A couple of other patients where such a similar results were noted. So vitamin B complex supplementation has been successful in treating patients with tobacco amblyopia, and the effect is believed to be because of the conversion of free cyanide to cyanocobalamin. So all patients had improvement in vision statistically significant, and the visual acuity and visual indices also improved. Although the use of Tuibur has been recorded before, but from our search, extensive search from PubMed, Google Scholar, Science Direct, this is the first study linking tobacco water or Tuibur to toxic nutritional optic neuropathy. So to conclude, nutritional optic neuropathy may be caused by a multitude of agents, and the mainstay of treatment involves replacing the deficient nutrients and eliminating toxins. And it is also important to consider the contributory social, cultural, and dietary practices. Thank you very much.
Thank you.
While we're taking questions, can we have Dr. Ruchi up on the stage?
Yeah, that's a very nice presentation, including the video. Why did you not think of giving methylcobalamin, the usual treatment for these?
No, we did give them methylcobalamin.
You have written only B complex.
Yes, B12 along with other things as well, yes.
B complex is not B12 with other things.
We
When I say
mostly-
methylcobalamin, I mean methylcobalamin 1500 micrograms.
15, that's what we tried. That's what we gave.
That's not
yeah.
B complex. B complex is B1, B6, B12.
And along with that, we added B12 as well. Yeah.
Dr. Himadri, the liquid what they produced
Yes.
and used to consume, have you done any chemical composition
No,
analysis
we
of
haven't
that?
done that. No, we haven't done that.
That could have
Yes, yes, yes.
increased the.
Yeah, we were planning to do that. Once we write the paper, we are planning for a few more patients. Once we get few more patients, we
7
will-
cases you have done.
Yes,
that
yes,
means
yes.
it's a case series, not
Yeah, not exactly a study. Yeah.
it's
So
a
we were
case
waiting for
study.
50 patients. Now it's an ongoing
And
study.
another thing, I just wonder how the vision has improved once the because you have showed that how many patients the vision improved.
All patients, madam. All patients had a good
This
vision.
is
yeah.
I wonder because in case of toxic neuropathy showing optic atrophy, the
No,
whatever
not
treatment.
much of optic atrophy was noted.
No, the picture which you showed.
Pictures showed that. That's okay.
How come the vision become 3/60 to
Yes,
6
yes.
by
We were
9?
also really surprised because mostly young, healthy people were consuming this. So otherwise, they had very good.
So
this thing.
what is your message from this?
We have to be aware of this condition, ma'am, because we were not aware. Initially, we were really surprised that what is going on. After investigating a little bit, we found out this is the thing. So I think we all should be aware that.
We are aware. But what you are going to tell them? What is your message to them? How you are going to make an impact to those people? Have you think of anything to
Yes,
do?
we are explaining to them that what you are consuming is very toxic.
That is more
Yeah.
important. Good study.
Thank you.
Welcome, Dr. Ruchi. Her paper is on clinical study of efficacy and safety of oral pilocarpine in the treatment of severe dry eye disease. Please go ahead.
Good afternoon, everyone. I'm here to give presentation on clinical study of efficacy and safety of oral pilocarpine in the treatment of severe dry eye disease. We have no financial interest to declare. Severe dry eye disease is a multifactorial disease with varied presentation of foreign body sensation with or without visual disturbance. When its presentation is severe and refractory to conventional therapy or tear substitution treatment, it can lead to a compromised quality of life. Our aim was to evaluate the efficacy and safety of oral pilocarpine in the management of aqueous deficient severe dry eye disease, which is refractory to conventional topical ocular tear film substitute. Prospective study was done on continuous 32 patients who fitted into our inclusion criteria. Study was conducted at Government Medical College, Betia, Bihar between June 2022 to May 2023. Patients of severe dry eye disease having Schirmer below 5 mm, disabling foreign body sensation and compromised quality of life were included in the study. Patients with history of allergy to pilocarpine, bradycardia and bundle branch block, gastritis, diabetes, glaucoma, peripheral myopic degenerations, and pregnant and lactating mothers were excluded from the studies. Informed consent was taken from each patient. Baseline pre-treatment Schirmer test, T-BUT value, global subjective responses were recorded and compared with those of post-intervention with oral pilocarpine tablet of 5 mg once a day for 4 weeks. And enrolled patients underwent general examination, fasting blood glucose level, ECG. A subjective overall symptoms were recorded. Fluorescein staining was done to see superficial epithelial erosion, if any. Infrared photograph of meibomian glands were also taken to look for any damage of the gland. Same repeated at the end of 4 weeks. Tear substitute and other treatment which the patients were taking were continued. 1 tablet of pilocarpine was given orally under direct supervision on day 1 at 11 a.m. Patients were directed to report any discomfort. Schirmer test, T-BUT value, and global responses were recorded 60 minutes after the oral dose of pilocarpine. Patients were prescribed the same dose of oral pilocarpine for 4 weeks, and follow-up was done on 1st and 4th week. Patients were asked to follow up after 1 week to assess any untoward effect, if any. At 4th week follow-up, Schirmer, T-BUT, and global responses were recorded and compared with those of pre-treatment. Here are the results of the patients who were included in the studies. Here's the summary. Overall subjective improvement was seen in all patients. There were mean improvement of 4.37 mm in the Schirmer value and mean improvement of 3.03 seconds in T-but. The result was analyzed by using two-tailed t-test and found highly significant for both T-but and Schirmer test. Pilocarpine is a widely used silolog. Oral pilocarpine is approved for management of dry eye in Sjogren's syndrome and has been ascertained to be effective in dry eye. Our study shows similar effect of improvement who were otherwise refractory to the tear film substitution without significant adverse effect, though we do not rule out that many of them may be a case of Sjogren's syndrome. So we can conclude that oral pilocarpine is a safe and effective in otherwise healthy individual in relieving symptoms of severe dry eye disease who are refractory to various tear film substitutes. Here are the photographs showing pre and post treatment references. Thank you.
Thank you, Dr. Ruchi. Question?
What are the side effects reported by the patients for oral pilocarpine?
So there were not many side effects, like minor side effects like salivation, sweating, gastritis. These kinds of side effects were mainly reported. We counseled the patient earlier, so the patient was like, okay, I'm going to face such kind of, so they didn't panic.
Long-term continuation means how many days the patient will use it lifelong or what?
Ma'am, we have given them for 4 weeks only, but we have not.
Dry eye is a lifelong disease.
Yes, ma'am, but we discontinue and then again we give. We do not give in a continuation period.
How you are going to implement it in your day-to-day practice? What is your message? For 4 weeks the patient will stop it just to see that the patient is okay?
Ma'am, as physicians,
or you have to continue it. How it works actually, pilocarpine and the conjunctiva and the dry eye?
Ma'am, there was study for Sjogren's syndrome. Physicians use oral pilocarpine 15 milligram dose. So in our case, we are not dividing the people in who are suffering from Sjogren's syndrome or who are healthy people. So we decided to give 5 milligram of dose.
See, the dry eye can be of the reason are various. It can affect the aqueous, it can affect the meibomian gland. In which particular group this is working? Have you divided them, classified them?
No, ma'am, it was like aqueous deficient dry eyes.
Aqueous deficient
yes,
dry
ma'am.
eye.
And the patient whose meibomian gland was healthy or kind of, we examined the meibomian glands and all.
Okay, thank you.
Thank you.
Dr. Sharma is going to be presenting her paper on agreement and precision of anterior corneal power measurements obtained using 3 instruments.
Good afternoon, one and all here. I'm Dr. Kshama and I'll be presenting, as already said, agreement and precision of anterior corneal power measurements obtained using 3 different instruments. The slide is here. I'll be discussing the study under the following headings. As we all know, an anterior segment surgeon has numerous diagnostic instruments available in the market for measuring corneal power. These instruments vary in terms of cost, accuracy, and ease of operating. Accuracy and precision is of utmost importance in cases of lens fitting, refractive, and refractive cataract surgeries. Hence, there is a pressing need for studies that assess the agreement among the different devices of anterior corneal power measurements, and such a literature would facilitate in informed clinical decision making. This study evaluates agreement of k-mean values, J0 astigmatic vector, J45 astigmatic vectors between 3 different instruments, that is AK, Topcon KR800, Tommy OA2000 optical biometer, and Sirius oculizer tomographer. Also, we assessed intra-observer repeatability and inter-observer reproducibility. The materials of this study, it was a cross-sectional study with 232 eyes assessed and patients with good vision with BCVA 6.6, good fixation and above 18 years of age were considered, and those patients having any active ocular surface pathology were excluded. patients attending our OPD after refraction, after registration history, vision, refraction, and NCT is recorded, an anterior segment surgeon sees the anterior segment, an assigned doctor sees the anterior segment, and those fulfilling the criteria are included in the study. After taking the consent, K1, K2, flat and steep axis were taken from each KR800, OA2000 and serious oculizer in the same order. And before each reading, patient was asked to blink. And then the readings were taken down and entered in the Excel sheet for analysis. The result of the study can be understood in three parts. One is the first is the agreement of K-mean values, J0 and J45 vectors. In our study, the K-mean values were interchangeable and were agreement amongst all three instruments. This was assessed using a Pearson's correlation coefficient. The value was being closer to 1 indicates agreement, and agreement of J0 values was not seen for both observer 1 and 2, and also J45 vectors were not agreeable. This indicates that the flat and steep axis obtained from the three devices are not interchangeable. Coming to the second part, intra-observer repeatability. Very high intra-observer repeatability was seen for K values, but not for J0 and J45 vectors. But this low repeatability was not significant. All three devices, 1 or 3 readings are sufficient because of good repeatability. The third part of the result is inter-observer repeatability, reproducibility. Significantly low inter-observer reproducibility was seen for all the three devices and for all the three values, that is K-mean, J0 and J45 vectors. This indicated that there has to be a surgeon has to rely on a single trained person to take the readings. In short, our study showed good agreement of K-mean values and intra-observer repeatability among three devices, and disagreement of J0 and J45 vectors was seen, and there was a significantly low reproducibility. There were other studies where they had one such study by Kinmai Wang et al. They had compared 8 different devices which included KR800 and serious oculizer, but they had not included OA2000. Their conclusion was that the K-flat and K-steep values between KR800 and serious oculizer was not agreeable, and they didn't assess the interchangeability of J0 and J45 vectors. Another study by Chen S. et al., where they compared Pentacam AXL and OA2000, the values were not in agreement, and repeatability and reproducibility was good for Pentacam AXL. Similarly, there are many studies, but they haven't assessed the astigmatic vectors, or they have not included OA2000 and Sirius in the same study. Concluding my presentation by saying that these three instruments can be used interchangeably for K-mean values, but not for J0 and J45 vectors. 1 or 3 readings are enough, and no need to take multiple readings, and reliance must be on one trained person for taking reading from a particular instrument. These are my references. Thank you.
Thank you, Dr. Namrata. Dr. Sharma. While we're taking the questions, Dr. Namrata.
Where do you think this will be useful?
So while deciding which instrument to be relied upon by a private practitioner or a practitioner in an institute like us, where there are multiple instruments, like we have a serious oculizer also and OA2000 also. So which should be relied upon?
For what cases?
Sir?
For what cases?
So for cataract cases, and mainly this is for cataract cases, sir, and contact lens fitting, which K values are preferred by each surgeon, that helps in decision making.
Okay, thank you.
Thank you.
Good presentation.
Go ahead.
Good afternoon, everyone. Today we are going to discuss color vision testing. Is online smartphone app an alternative to traditional Ishihara handbook? The assessment of chromatic discrimination ability and the diagnosis of any perceptual efficiency is color vision testing. It's a part of functional assessment of all the visual system by ophthalmologists. With the technological advancement, digital versions of commonly used color vision tests like Ishihara tests have now become accessible to the general public via online platforms. There are 3 cone receptors that lead to color vision: red, green and blue. Not all people possess trichromacy. Some are partially color deficient or completely color blind. The most common form of color deficiency is red-green color deficiency. There can be protanopia, protanomaly, deuteranopia, or deuteranomaly. Acquired color vision deficiencies may be seen in certain pathological conditions such as cataract and glaucoma. Color deficiency may be caused by ocular disease, trauma, or medication, as well as normal physiological process such as aging. The Ishihara test is a color perception test for red-green color deficiencies, and the first in class of successful color vision tests called pseudo-isochromatic plates. There are introductory plates, transformation plates, vanishing plates, hidden digit plates, diagnostic classification plates, tracing and pathway plates. With advancement in smartphone technology and medical software applications, we are increasingly incorporating smartphone applications. These are affordable and accessible, prevent delays in patient care while providers search for Ishihara handbook, solve the problem of shifting colorimetric values with the aging of physical color plates, and interprets its result by differentiating between color deficient and color normal. However, it is unable to classify the type of proton or deuteron of color vision deficiencies on its own. We did random observational studies with 120 participants of 18 to 30 years of age visiting the outpatient department. Informed consent was taken, visual acuities were assessed, ophthalmological assessment was done, and the testing procedure was carried out under standardized conditions for both the Ishihara and the smartphone app. The criteria for any participant to pass or fail was standard for the 38-plate Ishihara test, where 9 errors or more categorized as a participant as having red-green color deficiency and failing the test. Based on these results, participants were grouped as being color normal or color deficient. 52.5% were male, 47.5% were female, 4 out of 63 men were color deficient, while all women were found to be normal. The overall prevalence of color deficiency was found to be 3.3% for the sampled population. The sensitivity was the ability of the test to detect all individuals who had red-green color vision defect, and specificity was to detect who do not have any color vision defect. The sensitivity and specificity of digital version was both found to be 100%. The Ishihara handbook was used as the standard for comparison. The various responses from 4 men who failed screening test on the digital version was recorded. Minimum difference was seen on plate 7, 10, 17, 10 to 17 and 22 to 25. Most significant difference was seen between 18 to 21 plates. The digital version successfully differentiated the color vision deficient from the normal person, however, was unable to accurately detect the extent of deficiency. This may be because the identical depiction of slides of handbook was not possible, as these are scanned of graphic nature of the digital slides in the app. Combined sensitivity and specificity of the digital version and the Ishihara were 100% and 100% respectively. And combined sensitivity of the digital version of Ishihara test makes it efficient screening tool to detect red-green color vision deficiencies. Birch has a similar test with 401 participants, and it also found out that the red-green color deficiencies was found similar with the Ishihara handbook and the smartphone app. We have several studies like Gundon et al., Gantley et al., Hoffman and Mazzoni, Rodriguez, Cameron et al. They have tested with projected color slides, and they have proved that it is an effective and time-saving method. The digital smartphone application version of Ishihara's handbook is possible alternative to screening for color deficiencies in unavailability of the traditional handbook, and also provides a convenient self-screening alternative to in-office assessments or when test is required to be done by untrained personals. However, it has limitation as it is not able to accurately detect the severity of the deficiency. In case of participants who are positively identified as having color deficiency, a thorough in-office assessment is required to be carried out by an appropriately educated professional using the traditional Ishihara handbook in standardized conditions. Thank you.
Thank you.
Thank you. Dr. Tohida?
No question.
Any questions, ma'am?
No question.
So Dr. Tohida Sheikh is going to be presenting her paper on pseudoexfoliation, an entity beyond eye, a clinical study of various cardiac associations in pseudoexfoliation.
Good afternoon, everyone. I am Tauhida. I am going to present a paper on pseudoexfoliation, an entity beyond eye, a clinical study of various cardiac associations in pseudoexfoliation. Coming to introduction, pseudoexfoliation is an age-related disorder characterized by production and progressive accumulation of fibrillar extracellular material in ocular and systemic tissues. Its prevalence increases with age and varies considerably among population worldwide due to geographic and ethnic differences. It is more common in older age group, that is at late 60s and early 70s. It may be unilateral or bilateral. It is the most common identifiable cause of open-angle glaucoma worldwide. It is associated with cataract progression and various intraoperative complications. Major risk factors for pseudoexfoliation syndrome and glaucoma is polymorphism in the coding region of lysyl oxidase-like 1 gene located on chromosome 15q24, which plays a role in elastin formation. In addition to anterior segment structures, similar deposits have been identified in various other organs like heart, lungs, cerebral meninges, and kidneys, etc. Pseudoexfoliation syndrome appears to be associated with increased cardiovascular and cerebrovascular morbidity. Aims and objectives. This study was done to determine the various cardiac associations in patients with ocular pseudoexfoliation. Inclusion criteria. Patients diagnosed with ocular pseudoexfoliation on slit lamp examination after dilating the pupils with 0.5% tropicamide eye drops. Exclusion criteria. True exfoliation and other cause of secondary open-angle glaucoma. Material and methods. It is a cross-sectional study. Sample size is 50. The duration of study was from March 2023 to September 2023. The source of data is patients attending our OPD for cataract surgery, fulfilling inclusion and exclusion criteria. Investigations done are blood pressure recording using the manual sphygmomanometer, echocardiogram, 2D echocardiography, plasma homocysteine levels, and plasma lipoprotein A levels. This is a summary of my results. Coming to discussion part, this study was done to know the various cardiac associations of pseudoexfoliation syndrome and to emphasize the importance of cardiac evaluation in a patient with ocular pseudoexfoliation. In our studies, 56% had systemic hypertension and 22% were pre-hypertensive according to JNC8 classification. This signifies associations of pseudoexfoliation with systemic hypertension as suggested by other studies like French et al. Study, the Australian Blue Mountain Study, and Praveen et al. Study. The ECG recordings revealed 22% had abnormal conduction patterns, of which 18% had right bundle branch block pattern and 4% had left bundle branch block pattern. 8% had SC segment changes. This signifies the presence of abnormal ECG patterns in patients with pseudoexfoliation as suggested by Vardhan et al., a study conducted on South Indian population. 2D echo studies revealed 22% had mild reduction in ejection fraction and 36% had concentric left ventricular hypertrophy. It may be due to associated systemic hypertension. Blood investigations revealed higher plasma homocysteine levels and lipoprotein A levels in 34% and 32% respectively. They act as independent risk factors for the cardiovascular disease. Conclusion. Patients with ocular pseudoexfoliation may have an underlying asymptomatic cardiovascular abnormality. Hence, thorough cardiac evaluation is essential in patients with pseudoexfoliation undergoing cataract surgery to prevent intraoperative and postoperative complications. Our small initiative of cardiac evaluation may help the patient by unmasking a silent progress in systemic disorder before it can cause a havoc in them. My main emphasis by presenting this paper is we as the younger generation of ophthalmology need to look at ophthalmology as not only limited to eye but a subject beyond the eye. Thank you. These are my references. Thank you.
Thank you. Good presentation.
That's a very noble thought. But did you compare it with non-pseudo-exfoliation patients?
No, sir. Only the patients with pseudoexfoliation attending for cataract surgery.
No, the same thing. If you do it in a non-pseudo-exfoliation,
yes,
you can emphasize the importance of doing it in pseudo-exfoliation.
Thank you.
Great.
Thank you. I now invite Dr. Pallavi Prabhu to be presenting a rare case report where doctors turned detectives.
Very good afternoon. This is a case report where we doctors turned detective. I'm Dr. Pallavi Prabhu. This case practically blew us out of our minds. Every step, diagnosis, treatment, and management kept changing. And none of us were sure about the diagnosis or the etiology, and a lot of difference of opinion between the consultants were there. It was nothing short but a Pandora's box. A normal 48-year-old female walks into our OPD. She had mild watering, photophobia, and itching with blurring of vision. And she did have a history of allergic conjunctivitis on and off, which she was treated. And keeping into all the general and systemic examinations, where normal ocular examination yielded a early cataract was there with a grade 2 papillary changes, and everything appeared okay. So keeping all this clinical picture and everything into mind, from our first diagnosis came into picture, that was the allergic conjunctivitis. We treated her with the same treatment, and day 2 she was subjectively better. So we advised to continue the same. Now day 4, lo behold, she walked in. Look at that, there was worsening of symptoms. She had very severe photophobia. She was not even able to open the eye. There was no discharge, no corneal infiltration was seen. And with difficulty, when we opened the eye, she had a very large epithelial defect, and there was little DM folds. So immediately we stopped the steroids, put a bandage contact lens, started her on antibiotics and topical lubricants, and we started her on homemade eye drops. And now our second diagnosis kicked in, where it was an epithelial defect. The cause was not known. Now day 5, now this patient turned up, and she had a profuse purulent discharge, severe congestion. Out of concern, we were wondered whether she was putting the drops. We checked all the drops. To our surprise, the homemade eye drops which she was putting had white precipitates and was very turbid. And again, we doctors, we all went into huddle. We didn't understand what was happening. No clue at all. Okay, chalo, we decided. We removed the bandage contact lens. We decided to go in for culture and sensitivity grams and QH. And we changed to a different brand and a different batch. And we thought we should be seeing this case every day. We were still clueless. We didn't know what was happening. Now, the third diagnosis kicked in. That was the bacterial keratoconjunctivitis. On day 6, patient progressively worsened. Now the AC reaction was there with a small hypopyon, and the digital pressure went up. Again, a lot of huddle between the glaucoma retina department, not cooperative, patient was not opening her eyes. And again, we thought we will start with a fortified cefazolin, amikacin with oral acetazolamide. Instead of homemade, we put atropine. The day 7 to 8, she was status quo. And on day 9, surprisingly, the lab results came back. It was an E. coli, gram-negative bacillus. And the biggest challenge, how did the gut bacteria get into the eye? And that too for a normal female. And of course, sensitivity, whatever we were putting drops, it was very sensitive. So on day 12, slowly the cornea was healing. AC was little shallow. Fibrin reaction had reduced, and we thought we'll continue with the same treatment and keep watching. Status quo also on day 14. On days 16 and 19, she was much better, but there was now a persistent non-healing epithelial defect. She had, again, the digital pressure was okay. Now we thought like probably she's healing, but because of all the drugs which we have pushed into her eye, there was a lot of toxic keratouveitis. We should stop all the medication, put her on more lubricant, put her on plain chloramphenicol. And yes, we were still not convinced, but we went ahead. We asked her to take a higher center opinion, and she refused. And we insisted on an opinion. Now we had a non-healing epithelial defect with secondary glaucoma due to drug toxicity. On day 21, when she went to a higher center, the doctor there, she turned detective. She got an immediate pH test, which was done on both the drops. She got a fresh bottle and the patient's bottle, and surprisingly, the fresh bottle had a pH value of 7 and the patient's bottle had a pH value of 11. And immediately we had that in our lab, that homemade eye drops. We got the pH test done. It was lo behold, it was 10 and 11. Now the final diagnosis, hip hip hooray, we had was a chemical injury due to a deliberate tampering of the drops at home with an alkaline agent. And mystery was solved. The patient was cautioned, shifted to her brother's home from a son's home, and home nurse was appointed with a medication. And this was the plethora of the diagnosis we went through. And this she was on day 40. She was subjectively managed better. The discussion part here is these are the common household alkali like a baking soda, oven cleaner, or dishwashing powder or bleach which can be contaminated. The take-home message is please think out of box when things don't fall in place. Keep revisiting and learn from your findings. And lastly, literature search didn't give any much results. These are the references for the E. coli. This was the workplace medical mystery which we sorted out. Thank you so much.
Thank you so much, ma'am. Very, very well presented.
This will make a very nice episode on Netflix or something like that.
Detective होना पड़ेगा सबको.
Thank you.
May I now invite Dr. Harshita Krishna.
सबको डिटेक्टिव होना है या डिटेक्टिव.
So her paper is on evaluation of ocular anterior segment changes in pregnancy using stem plug technology.
Good afternoon, everyone. I'll be presenting about evaluation of ocular anterior segment changes in pregnancy using stream plug
Can
technology.
you come closer to the mic, Dr.
Go
Arshita?
closer to the mic.
So in pregnancy, most of the body organ system undergo changes, and it also includes the eye. These changes are mostly due to a rise in hormone levels like estrogen, progesterone, and beta-HCG. Corneal epithelium and stroma have estrogen and progesterone receptors,
Go
and these
closer
are
to the
not
mic. Go
spared.
closer to the mic. Yeah.
And these are not spared from corneal ectasia changes. Literature has reported many other changes like decrease in IOP, increase in ACA, ACV, ACD, and also changes in corneal density and thickness during pregnancy. So this study helps to compare the changes between the early and late stages of pregnancy in normal South Indian population. So the three main objectives of this study are to observe the changes in topographic measurements of cornea and anterior chamber, to observe the changes in densitometric measurements of cornea, and also to observe the changes in intraocular pressure during the course of pregnancy. So this is a prospective case control study with 31 healthy pregnant women as cases and 31 healthy non-pregnant women as controls within the age group 20 to 40 years. All the patients have undergone routine ophthalmological examination, including the sheen plug imaging. So the results are the mean age of cases is 24 years and the mean age of controls is 26 years, and the best corrected visual acuity of cases and controls is 6/6. On comparison of mean corrected IOP, there is a significant decrease of IOP by 3 mmHg in pregnant women by third trimester. Regarding the mean K1 and K2, there is no significant difference between the groups, and also there is no significant change in K1 or K2 at first and third trimester. On comparison of changes in central corneal thickness, there is a statistical significant increase in corneal thickness was seen in pregnant women compared to control group in the first visit. And the corneal volume showed a statistical significant increase at both first and third trimester. The corneal density has no significant changes in both cases and controls during the first and third trimester. Among anterior chamber depth, angle, and volume, the anterior chamber angle and anterior chamber volume has shown statistically significant increase in third trimester of pregnancy. On performing various correlation analysis, there is a statistical significant correlation between intraocular pressure and corneal volume, intraocular pressure and CCT, and corneal density and corneal volume. The mean age of cases was 24 years and the study population had a BCVA of 6/6. The corneal curvature did not show any changes in pregnancy, and the mean IOP has significantly decreased by 3 mmHg, which can be due to decrease in scleral rigidity, episcleral pressure, and also an increase in aqueous outflow. The corneal thickness changes can be attributed to the hypoosmolar state of cornea due to action of estrogen and progesterone on the corneal epithelium, stroma, and endothelial cells. Due to the hormonal influence during pregnancy, there is a significant increase in anterior chamber volume and anterior chamber angle, and also associated with a decrease in intraocular pressure. On conclusion, there is significant ocular anterior segment changes were observed in our study. As pregnancy is a physiological state, these changes should be carefully evaluated before treating diseases like progression of myopia, keratoconus, or glaucoma. The pathological effect of these changes can only be understood with its continued study post-pregnancy with larger sample size as well as the longer follow-up studies.
Have you compared it with any other studies done in any other places?
Yeah, we did not compare, sir, but similar outcomes were seen in the other studies also.
In South India itself?
Yeah, not in South India, other countries.
Nowhere in India?
One study was there, sir. That that also had a similar outcome.
What is new about your study? Is there any new message?
The study was not performed in the South Indian population, so we thought we'll just see
South
how
Indian
this-
population. Okay, thank you.
So welcoming Dr. Ladi Jeevan to be presenting his work on refractive outcome, optical versus ultrasound biometry modified with the Ladi method using premium IOLs.
Dignitaries on the dais and dear friends, comparison of target refraction with optical versus immersion biometry with Ladi method using Barrett Universal 2 formula after phacoemulsification with premium IOLs. This is copyrighted method, there is no financial interest. Aim is to integrate immersion ultrasound A-scan biometry with modern formulae like Barrett Universal 2. Advanced formulae require axial length of optical biometer. Need to integrate immersion with advanced formulae. Barrett Universal 2 formula is suitable for all axial lengths, that's why it is used in this study. It's a prospective randomized study approved by ethical committee. Study followed the tenets of Declaration of Helsinki. Informed consent was taken from all the patients. Patients above the age of 40 years ready for a follow-up up to 6 months were included, and vision-threatening complications of the eye were excluded. Masking and randomization, immersion group 100 patients, optical 100 patients. Randomization codes were done by statistical analysis software. Study coordinator revealed the type of biometry. Operating surgeon, optometrists, and counselors were masked. Continuous variables, group differences, normality of distribution, best-corrected visual acuity in log MR, categorical variables, group differences, univariate and multivariate linear regression analysis, outcome, and standard data with p-value less than 0.05 was considered statistically significant. All analysis was carried out as per protocol. Mandatory parameters of Barrett Universal 2 formula were used, it is axial length, antechamber depth, keratometry. Optical biometry group, axial length, antechamber depth, and keratometry group taken from the optical biometer, while from immersion, axial length was taken from the ultrasound, while antechamber depth and keratometry was taken from the sham fluid imaging. In Ladi method, 200 micron was added to the immersion ultrasound axial scan. Ultrasound cannot penetrate internal limiting membrane, while optical goes up to retinal pigment epithelium. The distance between these two is 200 micron. As per the study, foveal thickness is 212, while central foveal thickness is 182. So average for the study was taken as a 200 micron. Both optical and ultrasound parameters were entered into the Barrett Universal 2 formula. Study target was kept as a 0, except for EDOF patient. All variables, age, gender, visual acuity, and types of cataracts were almost same in both ultrasound and optical group with no statistical difference. IOLs were used where monofocal aspheric and a variety of multifocality IOLs were used almost same in both the groups. Visual acuity, spheres, cylinder at 1 month, 3 months, and 6 months were almost same in both the groups, and both the groups attaining target refraction in 73% patients. The Lovis diagram shows that target was achieved very well except for the extremes of the axial length. The group difference was only 0.2 diopters. Exact target refraction was 73% in both the eyes, while 0.5 diopter was 94 in ultrasound and 92 in optical, but not statistically different. Spherical equivalent, residual refractive error, both were within the range, achieving the target. No statistical difference. Ladi method of axial length effective with Barrett Universal 2 formula. Caution should be maintained at extremes of axial length. As per the previous studies, optical biometry is more accurate than immersion ultrasound in calculating axial length, but that values derived from both these machines may not be used interchangeably. After this study, Ladi method with ultrasound derived axial length is enhanced by 200 microns, appears to overcome this problem and provide refractive outcomes comparable to optical biometry. Drawback, this is not studied with swept source optical biometry, but even in swept source, in white mature cataract, you cannot get the readings. Advantages, randomized study, adequate follow-up, relatively good numbers. To the best of our knowledge, there are no studies looking at masking or making US-derived axial length compatible with the new IOL calculation formula like Barrett, Olson, Hill, RBS, and Kane. In conclusion, Ladi method adding 200 micron with Barrett Universal 2 formula is comparable to optical biometry. Further studies with larger sample size are needed with other formulas for widespread use of this technique. These are our references. Thank you.
क्या हो गया इसका? अरे?
Yeah, that's okay. Excellent study, Dr. Larry.
Thank you.
But majority of the places where people use ultrasound, they do not use topographer to do the keratometry.
So in this study, it is used as a, from, you can say, topography. You can use automated keratometry, which is available in most of the machines. Only thing, it has to be shifted to or adjusted to 2 decimal points, like 41.03, 42.05.
Have you done
Then,
that?
That is there. In topography, it is already there.
No, sir. I'm talking of keratometer, automated keratometer.
I have done it. It works well.
Not mentioned in this.
Not mentioned because it is not a part of the study, because it will get camouflaged.
Yeah. Thank you.
Because if I take reading from there, from where to take the anti-jumble depth, that's why both were taken from the same parameters. So that 3 parameters are not used in the same study. But if I tried it, it works.
Good study. But
So you try to basically compare the axial length from ultrasound vis-a-vis the optical biometer. That
Yes,
was
sir.
the ultimate. That was the main purpose of your study.
Yes, sir. And we are saying that ultrasound is equally correct if you are using with the modern formula, so that is going to compensate for the posterior corneal astigmatism, and there is no need of optical biometer. Thank you.
Thank you very much.
Immersion technology only, no?
Sir, sir.
With immersion, not contact.
No, sir, not contact. It is only immersion, sir. Thank you.
Thank you. Thank you so much. So now we've concluded the free paper session and move on to the much awaited AIOS Comprehensive Ophthalmology Award presentation by none other than Dr. Jitendra Jithani, sir. And he's a force to reckon with nationwide. He's a prolific pediatric ophthalmologist, and we've all learned from his landmark studies on childhood myopia. So over to you, sir. He's going to be talking to us about effective DIMS lenses on halting the progression of myopia, not responding to the LCA eye drops.
Thank you so much. Thank you for kind words. Respected dignitaries on the dais, I am presenting our work which we did last year on effect of DIMS lenses on children who are not responding to low concentration atropine. These are my financial disclosures. Now, first of all, what are the key factors as to why exactly myopia progresses in a school-going child? There are 2 major bulk. One is the near work, and second is because of the altered dopamine release. Near work causes peripheral hyperopic defocus. We had a paper on that. So the available literature on control of myopic progression says that, you know, with optical, you have these, some of these options that you have. And with chemical, you have low concentration atropine in variable dose forms, mainly in 0.01% and 0.05%. Who is a non-responder to atropine? Any child, if the refraction continues to progress, despite good compliance of more than -0.5 diopter per year, and an increase in the axial length of 0.2 millimeters is myopic progression, or it is a non-responder. The non-responders to 0.01% atropine ranges from 20 to 50% in various studies. The non-responders may be completely not responding even after putting atropine drops, or may have slowed down the progression, but yet they are continuing beyond 0.5 diopter. Now with this background, we decided to study the effect of MyoSmart or DIMS lenses as an addition with low concentration atropine eye drops on myopic progression in children who are not responding to low concentration atropine eye drops. We had around 10 children who were non-responders. They were enrolled in the study, who were already on atropine and were asked to continue atropine. This was a non-randomized single-arm interventional study with the glass power was increasing more than 0.5 diopter per year. The primary endpoint was progression at the end of 1 year. Now at the end of 1 year, these were our observations. The upper one shows glass progression and the lower one shows axial length progression. Now out of the 10 children, 2 children still progressed beyond 0.57 diopters. And if we take those into consideration, the mean progression would be 10 children. The reason these 2 children have been separated from the other 8 children is to know that there were the DIMS glasses were good enough only for 80% of children, and 2 children yet progressed. But if we will take all the 10 children, then we will see that the mean progression was 0.39. So that will have a masking effect, and we won't be able to know that it doesn't work in all the patients. So low concentration atropine drops are known to reduce the myopic progression. This is very well known. There was a paper in the previous session also. It has been years. Now this is the landmark study from where we all started using atropine by Audrey Chia. This was 1% atropine was used, and there was a follow-up study which was published in 2013. So it has been almost a decade. Now it is very well established that atropine does work. Non-responders to LCA drops are around 20 to 50%. The dose can be increased, or alternatively, we can prescribe peripheral defocus lenses. Now, DIMS is a defocus incorporated multiple segments, which makes peripheral refraction myopic and slows down the progression of myopia. This is very well documented that peripheral retina is actually responsible for the ocular growth. This was the study done in Macau monkeys way back in 2007, followed up in 2009. There was another study followed up in 2013, and the final study was published by Earl Smith III Jr. in 2016. I don't have all those studies, but this was the follow-up of his thesis. Lam et al. Showed that DIMS versus single vision lenses shows great progress. They showed that myopic progression was halted by DIMS lenses. There was a follow-up study in 2022. They reported a slowing down of axial length, and in their final 6-year study, they compared all the 4 groups, and they did show that DIMS glasses do slow down the myopic progression. The rebound effect is not significant, and selection bias was obviously one of the major limitations. With all these 2 modalities going together, we could not find a single study reporting what happens when you use atropine with DIMS. After we have already presented this last year, we saw one article came up last year. We already got this article published in AIOC that was published in last month of AIOC. So this is already there in publication. So this was one study in 2022 which talked about the possibility of using DIMS and atropine as an adjunct, but they did not publish the results. So we did peripheral refraction in all these patients. The study was unique, as I said, the DIMS was prescribed in conjugation with LCA eye drops. So in conclusion, DIMS lenses do show initial promise in reducing the progression of myopia in children not responding to low concentration atropine when glasses were given in conjunction with atropine eye drops. So thank you so much. Thank you.
What age do you want to start DIMS, and what age do you want to stop DIMS?
No. So this is a very general question. You can start at 5 years of age. So I always talk on myopia, and I say that you have to document the progression. The age at which you are comfortable at documenting the progression. If you have an axial progression documented, you can start DIMS. Unfortunately, children less than 4 years won't let you do axial length, and so bulk of the work is between 5 to 15 years of age.
Any upper limit of refractive error?
10 diopters. So DIMS lenses cannot be made beyond 10 diopters, and 4 diopters of astigmatism. Thank you.
Nice,
thank you so much. Thank you.
Thank you everyone for being here. We'll now leave after a photograph from the podium.